Yeah. Did we talk about DRGs? We were kind of just talking about that now, but you guys understand what a DRG is?
Yeah, it's expected length of stay. The first day usually they make it.
Yeah, but do you understand the concept of DRGs? Some places do some training on that and some don't.
No, I don't.
So it stands for Diagnosis Related Group. The words don't mean anything. You just have to memorize it. And the deal is, and for our hospital here at the university, 85% of our patients are on a DRG. So for our purposes, everybody's on a DRG, right? And a DRG means that the hospital gets a lump sum payment for the care of that patient depending on the diagnosis. And if they have, if they have community-acquired pneumonia, that's one. If they have community-acquired pneumonia with respiratory failure and they're on a ventilator, well, that's a different payment. If they have community-acquired pneumonia with, with sepsis syndrome, it's a different payment. I mean, within community-acquired pneumonia, there's different categories. But the point is that whatever that DRG is assigned, the hospital gets a fixed amount of money. It doesn't matter how much lab you order or how many x-rays you order. So if the patient has community-acquired pneumonia and you order x-rays every day, it's a minus for the hospital. Does that make sense? Every time you order something, it's a loser. So we want you to take care of patients, of course, and the way you're trained and the way your experience, we want you to exercise that. And if you think you need an x-ray, you get it. But if you But what we don't want to do is have unnecessary repetitive testing of lab and x-ray and daily electrolytes, BUN, creatinine. If they're normal 2 days and the patient doesn't have some, problem that's known to drive electrolyte abnormalities, stop it. There's an order that exists in our computer that says daily basic metabolic profile for 7 days. I don't think that should be used personally. That does not make sense for an internist. You're going to order that. If you order it for 3 days, if you order it for 2 days, it's okay. But really, you need to do those every day. I think you need to look at your labs and say, here's what my orders are. Another thing that's interesting about this DRG thing is, if we, I don't know how it was where you guys trained or worked before, but there's this kind of a philosophical thing that we used to do at university hospitals. I know I trained at University of Wisconsin, and it was this way in a lot of services. Patients coming here to university, we're going to do everything. We're going to work up their anemia, their hypokalemia, their secondary hypertension. We're going to do it all while they're in hospital, even though normally you do those things in the clinic. So here's an example. Patient comes in and they have community-acquired pneumonia, and they have an AST of 95 and an ALT of 96. Well, we're going to do a workup. I mean, that's abnormal. We've got to go after that, but we don't have to do it right now. The rest of their liver tests are normal. Their liver, their examination of their liver, they're not jaundiced, their bilirubin's normal. They don't need to have that right now. We should keep that on our problem list. We should put it in our discharge summary. We should make sure somebody responsible will work that up after discharge. But we don't have to do that, hepatitis panel, ceruloplasmin, alpha antitrypsin level, the usual huge workup, ANA, all this kind of stuff. Liver biopsy can be done later. If it's safe and you can defer it to an outpatient, that's what should be done. We focus on the problem that brought them in, get them better, get them out. If that patient comes into the clinic and we order all the 10 tests that we usually do for elevated transaminases, the insurance will pay for each individual test. There is no DRG in the outpatient world. So, makes sense, right?
What about,
yeah, please.
Most of the time, when we see patients, they do come with one problem, but then when you just they won't be complaining of something, but you find that thing.
Yeah. You just...
Then, will the DRG cover that?
It's possible. It's possible, yeah. It might even change the DRG. I'll give you an extreme example. Patient comes in and has a baby, and she has postpartum cardiomyopathy.
Right.
Terrible, I helped with cardiology a couple weeks ago, and we had like 3 or 4 of these patients with devastating postpartum cardiomyopathy, ejection fractions of 10, 15%, on drips, and terrible. She's in the hospital for a month. She gets a cath. Guess what? the delivery supersedes all that. They only pay for the delivery, not all that CCU care and all that other stuff. So it's kind of topsy-turvy. In other words, a patient comes in with communicable pneumonia, even though that's the first diagnosis. If they go have acute kidney injury, they get dialysis, it could change. It could be acute kidney injury, or it could be whatever, congestive heart failure. I don't know what it would end up as, but it could change. So you shouldn't worry about that. Just take care of the patient. If their liver tests are abnormal and they're having fulminant hepatic failure, well, of course, that's you gotta do what you need to do for the hospitalization. But just these things that the acid test is, can this be done safely as an outpatient? I would just ask yourself that. Yeah.
Can't one person be having 2 or 3 DRGs? Kind of
No. There's only one DRG. But there are some, it's terrible, isn't it? There are some modifiers, so major complications, major complications, and it could be a different DRG than what we're thinking it is. But there's only one DRG.
Is it make any difference if we are putting a problem list like a broad one initially?
We would want you to include all the problems. I mean, that's good patient care, of course, and that's being good internist. But yes, they use the problem list to determine the DRG, especially on the discharge summary. They will go back sometimes through the notes, but the coders use the discharge summary heavily. And it populates automatically with the problem list. Epic, you guys were on Epic before?
Yes.
So Epic has a problem list, and hopefully you keep that up to date. That's very important. And that is drawn into your discharge summary. And you can go in and modify that. You can say, make this text editable and go in and fix that. Because some of the things that come on the problem list don't make sense, like headache, NOS, and things that an internist would never write in a progress note, like pain in limb, no other specification. What does that mean? What limb was it, and what was it? Vascular occlusion? Was it musculoskeletal injury? I mean, I don't know what that means. So you have to kind of edit that a little bit. But yeah, they use that, and they'll use the primary problem. They'll use some labs. And that's the kind of impression I get about it. Yeah, I mean, we're not, we want to be paid for our work. We want to be given credit for what we did, and we're not trying to cheat the system or milk the system. I mean, this is just being appropriate and being good stewards of our resources, so that we have margin, so that we can build programs and build research and education programs and clinical programs, and we can take care of other patients. We can continue our mission.
I'm assuming that this DRG will also limit the excessive consultations as well, because it's gonna be a negative.
There's no, that's not part of it. So so the physician charges are separate. Strangely enough,
some won't include the consultation.
Correct.
That again another.
That's a physician side, and in fact, there was a note up there. They've erased it now, but when Mark Anderson came and he talked about consultation, it's a different system. The professional side, as they call it, the physician side, is separate. So you come and you admit the patient, you see them daily, you discharge them, you bill for that, and insurance will pay. Consultant comes, insurance will cover that. It's not part of the DRG. Yeah. Really good question. I should point that out more often, Yeah. Anything else on that? It's a really kind of interesting and subtle thing, and we don't tell residents about that. I don't know why. We protect residents from that knowledge.
I think the system we are trained, I still believe that this is not going towards the DRG, but I think in 2013 everybody has to go to DRG. This is more becoming
DRGs have been in place since the mid-1980s.
Okay.
And it might be that you were in a hospital that didn't have as many patients who were on a DRG.
Okay.
I don't know what the mix was. Like I said, ours is 85% DRG. So that includes all Medicare patients. In our setting, that includes all Blue Cross patients. And that's the vast majority of patients we see. We take care of prisoners from the state of Iowa, and they're on they're capitated, In other words, we get a lump sum from the legislature each year to take care of all the prisoners. And we have this thing called Iowa Care. Do you know about that?
Yeah.
It's for indigent patients. It's also capitated. So we get a lump sum beginning of the year from the legislature. You take care of all these patients. It doesn't matter how long they're in hospital or which clinics they go to or which doctors. This is the money. There's no more. You can do more x-rays or CAT scans or MRIs. You're not going to get any more money for that. So it's sort of the same thing as a DRG for us. There are a few commercial insurances that pay differently. Workman's compensation, but if somebody is hurt on a job, they pay everything. Boom. You send them a bill, they send it back by return mail. But as internists, we don't have people who are hurt on the job very much at all. I mean, that's orthopedic surgery, neurosurgery, you know what I mean? So. I have a note about ETC throughput, and I don't think we talked about that. So ETC, Emergency Treatment Center, and I think they're trying to change the name to the Emergency Department, back to that again, but you may hear myself or other people say ETC or ED or ER. We want to help them with their throughput. They have, they've gotten busier. They break the record. They've broken the record. 3 out of the last 4 weeks for number of visits in a 24-hour period. They're up to something like 187 visits in a 24-hour period now. So their reputation is getting better. Their patient satisfaction, their service is growing. Their volume is growing because of their good service, and so we need to help them get patients out. And so when they call for an admission, we should not be putting blocks in the way, like I want a CAT scan or a blood gas, or I want to get this GI consult before. If you have to have that, of course, yes. For instance, GI bleeder, you could say, have you called the gastroenterologist? And if it's a no, they often will call themselves. First, they see a GI bleeder, first thing they do is call a gastroenterologist. But if they haven't, you could say, okay, let's send the patient up, and would you call GI, or I will call GI and let them know. A CAT scan, let's say the patient's having abdominal pain, and you think they need a CAT scan, but they're going to be in hospital anyway. It's not going to change where they're at in the hospital, and it's not going to change the fact that they need to be in hospital because they need IV fluids and observation. So let's just get it on the floor. You know what I mean? It's just let the patient move through the system. If the ER doc is done with their thing, they are not going to do internal medicine workups in the emergency department. That's our job. They are going to determine if the patient needs to be admitted. Of course, they're treating patients with, fractures and, lacerations. They're doing their emergency doctor thing. But when they have a patient with abdominal pain, chest pain, electrolyte abnormalities, vomiting, stuff that we do, they're going to determine inpatient or not. And if they're inpatient, they're going to turn them over to us. They're not going to do a big workup. So it's throughput.
The CT scans and imagings, where are they located? Are they located on the floors, or they are located near the ED? How that is?
Both.
On the floors also we have?
Yeah, not on the medical floors, but the ED has their own, and then all the other imaging is on third floor.
Okay.
Yeah. So the ED has a very fast way of getting CTs. I don't think they have MR, but they have a couple of CT scanners down the ETC. And full X-ray, full plain X-rays. Yeah.
And the third floor is open in the nights too?
Yes.
Okay.
You may have to call a radiology resident for special testing, but you'll memorize their pager number, 3207, and you'll get to know them.
So will it be unreasonable just to say that, just get the CAT scan before he comes in, on the route kind of a thing?
It's possible. It's
we are
possible.
placing the order, but if you can just...
Yes, it's possible. Just discuss it with them, and if if they're backed up, they have trauma, they'll tell you. If they say it's going to be faster to get them upstairs first, then just do it.
Yes.
But again, our part is not to put any blockages in their throughput. Okay, so our agenda for today was to talk about ICU transfers, and that's kind of the same story, that we want to help them. They've already made a determination that it's safe for the patient to be outside the ICU, so usually we're not going to be coming back around and saying, hey, I don't think it's safe. It's possible, but that's really rare. A staff critical care physician has already made a determination that it's safe for them to come out. So we don't want to put blocks in like get another blood. If you think they need another blood gas, yes, get it, but don't just do it for fun, I don't know what else could happen. And so that's about patients coming out of medical ICU. Do you know about the critical care units we have here?
No. Actually, I wanted to ask about that.
Yeah, let's talk about that. So we have medical ICU, and that's, I think, the number of beds has been increasing. They've been expanding, they remodeled, and I think they're around 24 right now, plus or minus 2. And then we have a cardiovascular ICU, and it's a smaller unit. I think they have 12 beds. And then we have a surgical ICU, and it's a large unit. It's probably, it's at least 24 beds, probably more. Now, we're undergoing some remodeling, so those are all subject to change. One of the bays, as they call them, one of the pods in surgical ICU is closed for remodel right now. This CVICU is going to be closing. In fact, they're closing the whole cardiology floor. The 4JC, east and west, is the cardiovascular ICU and the main cardiology floor. That's all going to be closed. And the CVICU is, patients are going to be in the medical ICU. So they're going to be flexing those beds in medical ICU. It's going to be a little tight. And once they rebuild that, once they remodel that, just for your information, that is going to be all ICU. It's going to be shared between cardiology and cardiovascular surgery. So they're pulling those out of those post-op hearts. They're pulling those out of surgical ICU, and they're putting them in with cardiovascular ICU. And those beds are going to flex back and forth between cardiology and cardiac surgery. And those beds are also going to flex between critical care and step down. And we've never had step down before. We just don't have that here. And the point is that if one patient could stay in their bed, their status could change from critical care to step down, and their nursing ratio would change so that nurse would have 3 or 4, probably 3 patients instead of 1 patient, and they would stay in the bed. So that's nice for the patient because then they're not moving all over the hospital, I mean, the point is that the medical ICU is going to be very tight, and they're going to be wanting to move patients out, and they're going to be nervous. They're going to have patients in the ED who are on ventilators who need to come up, but there's no beds, and so your part is going to be helping with that throughput. And actually, we're planning to have a conversation between the critical care doctors and our hospitalists, especially those who do triage, probably in early August. We're just going to get together in a room and talk about the problems. So that's about patients coming out of the medical ICU in particular. So we do take medical ICU. We're committed to that. We are their main out. If a patient is admitted directly to the medical ICU from an emergency room here or other hospitals, or from another hospital, medical ICU in another hospital, they're going to come to us. Family medicine takes a few of those, but most of them are going to come to us. CVICU we take. Patient goes into CVICU with chest pain, and they, because of unstable and because of acute coronary syndrome, but they turn out to have a PE. Well, guess what? We're going to get that one. Those kind of things we get, or they have pneumonia. We're going to get those. So don't be surprised if you're called by CVICU if they don't have a true, primary cardiac problem. And we do take from surgical ICU. And a typical story would be patient came in with a bad intracerebral hemorrhage, and now they're palliative care. They're close to death. We'll take those. Neurosurgery is not going to do anything with those. That's our stuff, Or the patient had a long stay in surgical ICU after an abdominal catastrophe, a perforated bowel, and now they have acute kidney injury. Their surgical problem is done. They're having acute kidney injury and COPD and heart failure. Those are ours. You can take those. And you'll determine on the phone, both for patients coming out of units and also patients coming in from various other places, about whether they need telemetry or not. That's your call. If the emergency physician or somebody else says, I think they need tele, you can override that. I mean, one of the problems we have with that, though, is when the patient gets to, let's say you tell a person on the phone telemetry, and they get to the floor, and the team who takes them doesn't think they need telemetry. That's a bit of a problem, because now we got a nurse who's like, oh, do I work this patient up or do I not, and vice versa. So a patient comes to the floor and comes to 6 Carver. They have a potassium of 5.7, and you decided they don't need telemetry. They have EKG normal in the ETC, and the nervous resident gets them on the floor and transfers them. We're still trying to work that out. We don't want to move that patient around too much. It's very inconvenient for the patient and the nurses.
6 also doesn't take any teles?
No, it doesn't right now, but I should tell you, in the fall, they're going to go house-wide, what do you call it, virtual telemetry or whatever I forget what do you know?
Central telemetry.
Yeah, sure. Central monitoring.
Mm-hmm.
So we will have it on 6 Carver. So that would be a lot easier. They'll just take the monitor off, you know.
Right.
But in the meantime, we have these problems with transfers.
Cardiac flows right now.
Yeah, just the cardiac floors, 4 Roy Carver and 4 JC.
Okay.
And general internists like us get usually 4 Roy Carver. Occasionally you may have one on 4JC if it's totally overflow. 4JC is more reserved for the cardiology service. Yeah.
So just like somebody comes with a renal failure with, let's say high potassium.
Yes.
Even though the EKG is okay, we want to keep you on tele just because of the high risk.
You can have
it.
it.
Go to 6 or the 4th?
Fourth, as it stands right now.
Okay.
But sometime in the fall, it'll go. Yeah. They're remodeling the room, I noticed, on 6, not far from here on our floor, in the old building here, just before you cross over. They're remodeling some rooms where the monitors will be with the technologists who will monitor those. So yeah, but in the meantime, you have access. You can get tele whenever you want. It's possible that there might not be a telemetry bed. That's not unusual, in which case you can go to the medical ICU. And they're not real hot on that because they're reserving that for critically ill patients. But you might talk them into it, or they might have to stay in the ETC, the emergency department until a bed is available. All right. So that's about patients coming out of the units. About patients going into the units, let me say a few words. And what time's your next? I don't have the.
It's 9.
9.
We started late, I'm not sure.
Yeah, I don't know who. If they come in, I'll just stop again. But about patients transferring in, a few words. It's a little bit of a negotiation. I mean, obviously, if the patient coded or they're intubated, well, that's easy. But when you have a patient who's critically ill and you think should be in the medical ICU or the CVICU, you're going to be calling the fellow, critical care or cardiology fellow. And what I do is I just dial O and I say medical ICU, and when I get there, I say I'd like to speak with the fellow about a possible transfer. And if the fellow's right there, they give them the phone or they give you the pager number then. There's a place that you can get it on the paging system, but I just always dial O. And you'll talk to the fellow and you'll briefly present the patient. The fellow will usually come to the bedside. They'll usually come right down and look at the patient with you. They may say, why don't we try 15 minutes of fluids or some supplemental oxygen. They may give you some advice, and let's try a half hour to an hour and reevaluate, and if you think that's safe, that's fine. At that point, if you don't think it's safe, you can give them a little stronger case, or you can talk to their staff. And their faculty members are committed to this backup evaluation. Faculty members are in the house for critical care units a lot of hours during the day. Medical ICU has 2. They have a day and then an evening faculty member. So they're here staffing the patients. I don't know exactly what time, but roughly from 7 to 10 p.m. So you may, 20 hours per day, you'll get a faculty member who's in the building. Then you're welcome to do that. And this kind of goes to the next subject, which is the rapid response team.
Yeah, I think this speech is.
That's right. Yeah. And I may have told you about that during the interview process because a lot of people ask about that. But our faculty members, our hospitalists, are not formally part of the rapid response team or the code team. But of course, if your patient is coding, you are expected to be there, and you're not the leader of the code team, but you're giving advice, and you know what the underlying diseases are. You may know the family. You may know the patient's wishes. You may go out and talk to the family during the code. You're there helping. You may know that they've been hypokalemic or hypercalcemic during the day, and you might know we better look at some labs right away. So you're thinking outside the box during this code, For the rapid response, so the code team is the senior medical resident, an anesthesia resident who's going to manage the airway, a surgery resident who's going to be available for a central line, but as you know, during ACLS, you don't have to have a central line. If there's no other access, yeah. But if you have good IV, especially if you have 2 good peripheral IVs, you've got to tell those guys, hey, hang on a second. You might be helpful in telling the surgery resident, we don't need that line right now, because that's going to interrupt CPR, and it could be complications of central lines, which we don't need. Respiratory therapists and a bunch of nurses will come to this code. The rapid response team is the senior surgery resident for surgery patients. That's not us. So including ENT, OB-GYN, urology, senior surgery resident. For us, senior medicine resident, a senior respiratory therapist who doesn't have other patient care duties, and a senior nurse in a unit who doesn't have other patient care duties. And he or she will know how many beds are available and where in critical care units. That's their part. So the nurse is there to help with transfer if you want it. The respiratory therapist is there to help with bag and mask or supplemental oxygen, those kinds of things, or breathing treatment, And the senior medicine resident can be there for whatever you want help with, fluid resuscitation, calling a unit, whatever you think you need. But they're there to help you, to advise you during this rapid response. A few scenarios. A nurse may have called the rapid response team, and you get there and you give a 500 cc fluid bolus, and the patient's better. Hey. Then you can just say, thanks guys, everything's under control, we're not going to transfer this patient. It might be that you get some help from them, and you transfer the patient, and the patient didn't really have any problem after all. They go to the unit. This is talking about going into the unit. Patient has some vital sign abnormalities. They're hypotensive, and they're hyperthermic, and they get a fluid resuscitation on the floor, and they go to the unit overnight. They do fine. They're already on antibiotics, and they come out the next day. That's fine. No big deal. It's good. We want that. In fact, you guys may know that patients who code on medical floors, their survival rate to meaningful neurologic recovery and leaving the hospital is around 15%. 18, 17%, all places. Our place, we've studied it here, nationwide, same numbers, not good. Patients who code in critical care units, about 50% survive to meaningful neurologic recovery. So if you're going to code, you want to be in the unit, right? It's not that we're just we're changing the place where they code, but that's a good thing. It's probably because they're monitored more closely, and the CPR is started sooner, this code blue is started sooner, rather than having a prolonged period of time where they're not observed by a nurse and they have brain damage or brain death. So yeah, that's the purpose of the rapid response team. You may know that nationwide the numbers have not been good in this country for rapid response teams. In Australia, survival and mortality, they use gross mortality in hospitals much better in Australia after rapid response teams were started. Not so in this country. But our numbers are good. After we started, I was on the committee that helped with the rapid response teams, and our mortality improved when we started them. So they're helpful. Trying to think of any questions about that, or okay.
It's ultimately, if it is your patient, obviously they are helping you out.
Yes.
You are the one who are transferring the patient and maybe putting a note and everything.
Exactly right. Yes. Yes. Yeah. One other thing about the rapid response, you know, myself and the Dr. John Fieselman, who's a pulmonologist who's in charge of rapid responses, and the committee and everybody in the hospital wants these rapid responses to go forward with a very low threshold. That is, we want the nurse to be empowered and to go with that if he or she thinks they need that. It helps the nurse too. It helps you, but it also helps the nurse because he or she is going to get extra staff in the room immediately. The threshold that we've set is very low. If there's one vital sign that's abnormal and one person is concerned, like the nurse, they can call. It's two, so they need two things, but one of them could be a concern, any concern. Doesn't have to be an objective number. There was talk about letting family members do this rapid response. That didn't go through, but that's the idea, that's the flavor, that we want it to be very low. So we as physicians should not be saying to a nurse, do not call a rapid response. If a nurse says, I'm calling it, we let it go. It could, the team may come and you can say, here's what's going on with the patient. Do you have any other thoughts? I think the patient is stable now. I'm planning to do this. I don't think they need the unit. And then they'll leave.
This is not a failure. This is just to get the more appropriate help and everything.
That's right. That's right. It's not, a reflection on your care or anything. Don't take it the wrong way. But we don't want you to block or interfere with the process.
Actually, in the hospital we were trained, family members were allowed to.
Oh, were they? Yeah.
They were allowed to
Nurses, family members.
How was that? Was that good?
I think that was a good idea. I mean,
Yeah.
definitely there was some, you go over there and you take a manual blood pressure and it's normal, it's just a cough problem.
Mm-hmm. Yeah.
But there are other times where actually, sign out some morning, you are busy with your roundings and then the nurse called and then the patient actually need the help. So it's, you have to, the nurses initially were like, you have to train everybody.
Sure.
So it's not like it's a concern, but actually if they are taking one vital, like manual one, if they are really concerned, go ahead and do that.
That's good.
So it's usually, I think with the passage of time, it gets better. Initially, you will get a lot of things which you don't require it, but you start from that point and then you progress to a better one.
Yeah, good.
But even in that case, what I felt was, even if the family member was empowered to call the call, I think if something happened, if they were concerned, they still call the nurse.
Yeah.
So nurse nurse ratio on a regular floor was what, 1:4 if I'm not wrong.
Yeah. So you're saying the nurses were pretty responsive if they were called? Yeah.
So the patient, or the members, because they are always there in the room.
Right.
Even the. That was probably the thinking behind was to cut down that response time.
Right.
Because the family member is always there. The nurse still has 4 other patients to take care of.
Yes.
So the family member is concerned. Typically, they do call the nurse. The call button is right there.
Yeah. Right. I do hear from family members though they called the nurse and it took too long.
Okay.
But I don't know what too long means.
Okay. Because usually if you call the number and suppose the nurse is busy, that goes to ACT, like the technician.
Yeah.
And then they ask, may I help you? And if they're saying patient is not doing fine, then either that nurse or the backup for that nurse have to go immediately and see.
Yeah.
So because there's always a backup to that nurse
that's
within the nurses.
We need that here, I think. Yeah, that's good.
So, usually it's pretty fast.
Yeah.
So that's very good for the patient care. Ultimately, we realize that ultimately it's going to help the patient.
Sure, absolutely,
Yeah, at times it can get frustrating too because there might be some family members who is always on the edge kind of a thing.
Yes.
But then that's the pitfall of a good thing.
Yeah.
Agreed.
It depends.
Yeah, right. What else? Any other questions or things that you guys wanted to bring up?